Alright, I'm going to continue the lecture for disorders of cardiac function for chapter 19. We had kind of left off talking about angina. So, clinical features and treatment of ischemia. There are 4 different types of ischemic heart disease, and they are angina pectoris, myocardial infarction, chronic ischemic heart disease, and sudden cardiac death. And these are, again, all due to progressive coronary atherosclerosis. So the first one is angina, and we'll talk a little bit about that. Okay, so you can see we have a couple different types of angina. So basically, angina is intermittent bouts of chest pain that are generally brought on by exertion, and they should be relieved by rest. No permanent myocardial damage occurs right now. So we have a couple different types. As you can see, stable angina is the first type. And this is the type that we have chest pain and then it's relieved upon rest. And there is no damage left. Unstable is generally classified by a more intense pain, and it comes on, it's kind of unpredictable. It doesn't just come on with exertion, it can come on with other things, and it's not always relieved by stress, or by rest, pardon me. Variant, and it's not on this chart, but it's called Pritzmetal angina, and I think I spelled that out on the board for you guys. Basically, it's unpredictable attacks of anginal pain. And most of these people do have pretty significant coronary artery disease, although there are some other things that can bring it on. Physical or emotional stress, smoking, alcohol, sudden temperature change, and cocaine use. And it can be caused by a vasospasm or a short-term thromboemboli formation. Sometimes it's just unknown and they never really figure out what caused it. A lot of times treatment for these things are calcium channel blocking drugs and nitroglycerin. So our next one is acute ischemia and myocardial infarction, or MI, heart attack. Here's your treatments. Okay, so myocardial infarction is most often caused by a thrombus, but it can be caused by other things. And this is a prolonged or severe ischemia, and this does leave behind damage. And classic symptoms are unrelieved chest pain, nausea, vomiting, diaphoresis, shortness of breath. Sometimes inflammation can occur. And we talked again in class a little bit about how women can present with different symptoms sometimes than men. They tend to be a little bit subtle. So, when we talked about coronary arteries, depending on where that thrombus is, depends on what part of the heart is going to be damaged by this myocardial infarction. And you can see here that necrosis really starts 20 to 30 minutes after that coronary artery is occluded. That's why you'll see this push for hospitals, that we want to get people in the door that are having chest pain into the cath lab right away so that we can open up that blockage and hopefully reduce the amount of damage that's done to the heart. And you can see here how that necrosis can evolve over time. And depending on where you have that occlusion, it will progress. So, what do we look at when someone comes in and they're having chest pain and we want to rule out what it is? Well, we look at cardiac enzymes. And our cardiac enzymes are our CKMB. They can also be troponin is another thing that we look at very closely. And you can kind of see here in myoglobin. Sometimes we'll look at LDH. and CK as well, but you can see how they progress over time. And we usually look for that peak in troponin, and then as it comes down, we kind of know that hopefully the damage is not going to extend anymore. Okay, and you can kind of see here, based on what coronary artery that occlusion is in, where we might have some damage to our heart. That LAD, or that left anterior descending, that's also called the widowmaker, and usually that one is the most common cause of sudden death because of where it's located and what it supplies. So if you look at this, this is a heart on someone that died of a heart attack. You can see the damage that's been done to the tissue. And then this is kind of the sequel of events. And when we look at MI, another real easy and quick thing that we can look at is actually EKG changes. We'll see changes with different types of ischemia. So we can see, usually the most common here is an ST elevation. We can see peaks in our T wave as well, flattening, inversion, and then we also get these bigger Q waves. So when we look at the zone of ischemia, if you kind of go back to that other slide, when we see that T-wave inversion, it means really that our myocardium is ischemic, but that those injured cells are still viable. Okay, so that would be when we really want to get someone to the cath lab, open up that artery. We're going to see, for a zone of injury, a major decrease of blood flow, and therefore we're going to see this ST elevation. And then zone of infarct. So at this point, our cellular necrosis, death has occurred, it's irreversible, and this is where we get that deep Q wave, and there's a lack of depolarization from scar tissue that's been built there. So if you look back on your normal EKG, you can see the difference between these two. So treatment, obviously we need to dissolve that clot within 6 hours. There's a couple different things that we can do. We can give a clot buster like plasminogen, streptokinase. Sometimes they go to the cath lab. A lot of times they go to the cath lab and they either need to open that artery with a balloon. Sometimes they'll need emergency surgery. Damage really is irreversible 6 hours after they're already starting to form that scar tissue. And basically, treatment of acute ischemia, we want to decrease that myocardial oxygen demand. So we're going to try to use rest, try to control heart rate, pain relief, and afterload reduction. Something we use is called nipride. And we're going to increase that oxygen delivery. Okay, so that's why everyone is treated kind of the same with MONA, M-O-N-A. So morphine, we give morphine because it actually does help increase oxygenation, but it's also going to help with pain relief. Oxygen, anyone who has any sort of chest pain is immediately going to be put on oxygen so that we can increase the oxygen flow. Nitroglycerin is the N, so everyone's going to get some nitro because we need to see if it's relieved or unrelieved. And A is aspirin. So everyone's going to get aspirin immediately. And that's obviously to help with the thinning of the blood. And so here are some of our compensatory mechanisms, and we've talked about these before. Because we're going to have a decreased stroke volume, we have immediate, which is our basoreceptor activation, and our SNS, and then we go to our renin-angiotensin aldosterone, increasing our preload, and then after that, if we've had enough damage, we're going to have that LV, which is going to start to get hypertrophic. And here you can see some of the problems as they progress. So if we have someone that has a bad enough infarct, they could have sudden death. After that, they're really at risk for shock, arrhythmias, congestive heart failure, and even following that, they're really always at risk for heart failure and arrhythmia in the future, up to 10 years in the future and beyond that. So here are some possible complications of MI. We have obviously the infarct. There can be thrombus formation. They can develop aneurysm and then rupture, which is very rare, but it does occur. So summary of events following an MI. So we talked about, it breaks it down between partially ischemic cells and totally ischemic cells, and you can see some of the differences. So partially ischemic, we're going to end up, we could have some dysrhythmias, ST changes on our EKG, and then for totally ischemic, also we can end up increased heart rate, vasoconstriction, and Q waves, and then that's where we're also going to see our increased cardiac enzymes, and shows you why our enzymes are being released. Okay, so a couple more things on MI. We talked about signs and symptoms, EKG abnormalities, cardiac arrhythmias. People can go into what we call cardiogenic shock. I'm going to move forward here and then I'm going to go back. There's a slide on the pulsus paradoxus that we had talked about before with tamponade. Okay, I'm going to talk a little bit about myocarditis and then endocarditis, and then we'll go back to the valves. Myocarditis is an inflammatory disease characterized by scattered necrotic and dead heart muscle cells, and these are most often associated with viral infections such as hemolytic strep. And basically the major complication is the dilation of the four heart chambers, and this gives us reduced contractility. And some of these fall under our cardiomyopathies. So let me go back here. Okay, and we've talked a little bit about cardiomyopathies, and they're basically a number of disorders, and they can be genetic or acquired, and they're generally not inflammatory. The first one that we have is dilated cardiomyopathy, which we talked a little bit about before, and that's just the enlargement of all four chambers of the heart, and then you get that reduced contractility. The next one is the one that's on this slide, and that's the hypertrophic cardiomyopathy. And it usually affects the left ventricle and the ventricle septum. A lot of times this can be a genetic cause, although there are other causes such as anything that really increases contractility of the heart. So drugs, hypertension, and it results basically in an obstruction of the ventricle outflow and reduced cardiac output. And then over time, that left ventricle tries to compensate, and this is what happens. There's also another type called restrictive cardiomyopathy, and that's basically characterized by a stiff, fibrotic left ventricle. And they start to have decreased cardiac output and then end up having left-sided congestive heart failure as well. Oftentimes cardiomyopathy needs to be treated, it can be treated medically for a while, but the end result is usually cardiac transplantation. Okay, so now back to endocarditis. So endocarditis is actually fairly uncommon, but it can be life-threatening. And it's an invasion of the heart valves that leads to vegetation and destruction of the valves, and it's usually bacterial. Okay, now this one shows from rheumatic heart disease. But generally it's a bacteria that gets in and it attacks the heart vessel. Strep is usually the number one cause. And rheumatic heart disease, those previous slides showed a little bit about rheumatic heart disease. Lots of things can lead to it. Some of the other symptoms will include fever, joint pain. Again, we can see a prolonged PR interval, and then the valves become inflamed and actually have wart-like growths on them. Sometimes this can resolve if we catch it early enough and we treat it. Other times, these people will end up with chronic valve disorders. Okay, so you can see here the bacteria infecting the valve. And then here again, this is a real lovely picture of bacterial endocarditis. These patients will end up often having to have their valves replaced and treated with extensive antibiotics. And you can see some of the other things that can result. Obviously, if we have vegetations and things in our valves, not only are our valves not working, but these things can spread all over our body and cause a variety of different dysfunctions. This talks a little bit, we're going to talk about mitral and aortic valve disease. So, valvular disorders, we kind of classify them under two different types. We have stenotic valve disorders, which are a failure of the valve to open properly, and this causes an abnormal pressure gradient across the valve and increases the pressure work of the heart. And then we have regurgitation, which is when the valve allows the blood to flow backwards across the valve, which results in extra volume work for the heart. So mitral stenosis is the first one that we'll talk about. And it's characterized by a large left atrial or left ventricular gradient during ventricle diastole. And mitral stenosis leads to left atrial and pulmonary congestion. So as you can see here, what's happening is that valve is really tight. So the left ventricle isn't filling as well. So now there's this increased pressure in the left atrium. Mitral regurgitation increases, again, the workload of the left atrium and the ventricle. That can lead to heart failure because of the regurgitation, it's flowing backwards, which is actually here on this next slide. And it's kind of the same with the aortic. So aortic stenosis, that valve isn't opening properly, we're not getting that fill, and we're getting an increased pressure gradient into the atrium, and then the regurgitation again, it's flowing backwards, so it's increasing there. So this is where we will hear murmurs. Okay, so if a valve is stenotic, you'll hear a murmur of blood shooting through the narrow opening when the valve is open. And if it's a regurgitating valve, you'll hear the murmur of the blood leaking back through the valve because it's not closed. So we're going to talk a little bit about shunts and then some congenital abnormalities. So basically a shunt is an opening or connection that lets blood move from one side of the circulation to the other. Most shunts occur in the heart and move blood either from the left to the right or vice versa. And because the left side is stronger, blood is usually pushed from the left to the right side. So before birth, we have actually several shunts that are normal, and they're the foramen oval, the ductus arteriosus, and the ductus venous. And unfortunately, sometimes babies are born with these without them closing up appropriate like they should. So congenital heart disease. About 25,000 babies a year are born with a heart defect. They can be minor, asymptomatic. Sometimes they resolve themselves. It just takes a little bit longer, but they can also be major and have, major clinical complications. So after birth, there are some circulatory adaptations that happen. So after the umbilical cord is clamped and cut, those umbilical arteries and veins actually collapse and become fibrotic. And then when the lungs start to expand with air, blood pressure in the pulmonary circuit drops rapidly, and pressure in the right heart falls below that in the left. And at this point, that foramen oval is closed as two flaps of tissue are pushed into place. So that's how that shunt closes. And then the ductus arteriosus closes permanently about 3 months of age, and it leaves a permanent residual ligament. And sometimes in premature infants that PDA isn't closed, they can actually give them prostaglandins, which will help close it. So a couple different things that cause congenital heart disease. Sometimes it's just unknown. They're not really sure. It can be something genetic, chromosomal. It can also be a virus, and alcohol or drug use on mom's part. So all our congenital heart defects have two primary pathologies. The first is the shunting of blood through abnormal pathways, and the second is obstruction of blood flow due to an abnormal narrowing. So these are some of the most common ones, and if we talk about acyanotic congenital defects, so this means that we have no mixing of blood. And these include our atrial septal defect. So in our atrial septal defect, blood flow is usually from the left atria to the right atria. And really these babies and children actually can be asymptomatic for years. But there is a long-term increase in pulmonary blood flow, which can eventually lead to pulmonary hypertension, right ventricle hypertrophy, and a reversal of the shunt. Another acyanotic defect is ventricle septal defect. So this is a left to right shunt that may heal spontaneously if it's small, but it can cause some of the same problems as atrial septal defect if it's large enough. And then that patent ductus arteriosus, so that's that normal channel between the pulmonary artery and the aorta that remains open while baby's in utero. After birth, it should close, but if it doesn't, it allows blood to flow from the aorta into the pulmonary artery. This usually closes spontaneously, or sometimes we can do medication, and if not, this is where we really have to do surgery on these babies, because otherwise they'll go into respiratory and right heart failure. So this is our normal development of a heart. This is the ventral septal defect. One of the other acyanotic congenital defects is coarctation of the aorta, and that's that narrowing or stricture in the aorta that can impede blood flow. And it's a common defect that affects males 3 to 4 times more than females. And how do we determine this? It's usually noted by hypertension in upper extremities and decreased femoral pulses. And if you think about the fact that it's because there isn't enough pressure to pump all of the blood through to those lower extremities. The next one is pulmonary stenosis. And this kind of occurs a lot of times with other abnormalities. Aortic stenosis. So again, babies can be born with aortic stenosis, just like an adult may develop over time. So now we move on to cyanotic congenital disorders. And cyanotic congenital disorders obviously cause cyanosis. So they're more, you would notice these earlier, they're not going to be asymptomatic. And these babies are going to have to be treated. The first one is tetralogy of Fallot. So tetralogy of Fallot has 4 defining features, and they have a ventricle septal defect. That's the first feature. The second is an aorta positioned above the ventricle septal